So now we're going to move on to antiarrhythmic agents. Antiarrhythmics are used for the treatment of fast, slow, or irregular heartbeats. Most drugs used as antiarrhythmics in primary care are used for other indications as well. For example, amiodarone and dronedarone are the only drugs that are used exclusively for arrhythmias. Primary care provider who has a patient taking an antiarrhythmic should consult the most recent sources for complete up-to-date information on the drug, and should work closely with the patient's cardiologist, electrophysiologist, or physician. All antiarrhythmic medications have potential serious adverse effects, including the induction of other serious and even fatal arrhythmias. So these drugs need to be prescribed cautiously and monitored closely. So let's take a look at the drug overview. Antiarrhythmic drugs act to reduce electrical irregularity of the heart. To do this, they must alter the action potential of cardiac cells. All antiarrhythmics have the potential to cause arrhythmias. There was a study in 1995, the CAS study, which is a cardiac arrhythmia suppression trial. This is the trial that revealed the dangers of aggressive medical treatment of arrhythmias because of the development of causing, or the potential to cause, other arrhythmias. These are broken down into classes. Class 1 includes Class 1A drugs, quinidine, etc., procainamide. These depress rapid depolarization, phase 0 of the action potential. These drugs act to slow conduction by lengthening the effective refractory period of atrial and ventricular myocardium, by depressing the inward sodium current, and by decreasing the automaticity and excitability of the topic foci in cardiac muscle. The Class 1B drugs, such as lidocaine, most commonly known, exerts less of an effect on sodium channels at rest, but are more prominent during depolarization. So their effect on phase 0 is only slight. Class 1C drugs, such as flecainide, propranolone, depress phase 0 markedly and profoundly slow conduction. Class 2 drugs include beta blockers. These antiarrhythmics work by inhibiting sympathetic stimulation. They antagonize the effects of catecholamines released from the adrenergic nerve endings and the adrenal medulla. Blocking sympathetic activity results in reducing the rate of discharge of the sinus and other foci that act as pacemakers, thus increasing the effective refractory period of the AV node. The Class 3 drugs include amiodarone, most commonly known, sotalol. These drugs prolong phase 3 repolarization by blocking potassium channels. The QT interval is prolonged when these drugs are taken on the EKG. This prolongation also increases the risk of torsades de pointes, which is a ventricular tachycardia. Amiodarone, however, does not appear to have this effect. Amiodarone seems to block sodium channels, and this contributes to slowing of conduction and prolongs refractoriness of the AV node. Its vasodilatory action increases cardiac workload and therefore decreases myocardial oxygen consumption. High mortality rate in patients with AFib, fibrillation taking these Class 3 drugs have been reported. There's a question of whether they'll remain on the market other than the amiodarone and sotalol. There's some indication they prolong on QT intervals. Sotalol exhibits beta blocking activity. Ibutylide is available only as an IV formulation and is used for rapid termination of atrial fibrillation and flutter. Most of these other drugs are used in hospitalized patients that are closely monitored. The class 4 drugs include the calcium channel blockers such as verapamil and diltiazem. These drugs inhibit calcium ion influx through slow channels into conductile and contractile myocardial cells and vascular smooth muscle cells. They also slow AV conduction and prolong the effective refractory period within the AV node. Finally, digoxin and adenosine. Digoxin suppresses the AV node conduction to increase the effective refractory period and decrease conduction. This results in a decreased heart rate and reduced risk of re-entry or subventricular arrhythmias. So what are these medications used for? Their indications are for paroxysmal subventricular tachycardia, atrial fibrillation, and premature ventricular contractions. Again, they decrease electrical irregularity by altering the action potential of cardiac cells. Again, all antiarrhythmics have the potential to cause arrhythmias. The class 1A drugs depress rapid depolarization or phase 0 of the action potential. Class 1B drugs exert less effect on sodium channels at rest but are more prominent during depolarization. So their effect on phase 0 is only slight. Class 1C drugs markedly depress phase 0 and profoundly slow conduction. Class 2 antiarrhythmics work by inhibiting sympathetic stimulation. Class 3 drugs prolong phase 3 repolarization by blocking potassium channels, and this results in the QT interval being prolonged on EKGs. Prolongation of the QT interval increases the risk of torsades de pointes. Amiodarone, however, is the exception. The class 4 drugs, calcium channel blockers, inhibit calcium ion influx through slow channels into conduction and contractile myocardial cells and vascular smooth muscle cells, and slow AV conduction. They prolong the effective refractory period within the AV node. Digoxin suppresses AV node conduction to increase the effective refractory period and decrease conduction. So what are the cardinal points of treatment? The primary care provider must work in collaboration with the cardiologist. You should not be prescribing or managing these drugs alone. The cardiologist determines the appropriate medication and begins treatment, and the patient, once stable, may be turned over to you for long-term monitoring. So for pharmacological treatment, paroxysmal subventricular tachycardia, these drugs are for prophylaxis of PSVT, usually involves digoxin or beta blockers. Verapamil is often a second choice. These medications also may be used in combination. It must be remembered that the verapamil increases digoxin serum levels, so you need to be very cautious if the patient is on this medication. If the patient has significant heart disease, he or she may require a class 1A, 1C, or 3 drug. Radiofrequency ablation is frequently used to eliminate the accessory pathways and thus helping to control these arrhythmias. This avoids problems with the safety of antiarrhythmic drugs. Digoxin and calcium channel blockers should never be used if and accessory pathway is diagnosed or suspected. For atrial fibrillation, the treatment is threefold. It controls the rate, rhythm, and thromboembolic events. The control of rapid ventricular response is accomplished with the use of beta blockers or calcium channel antagonists for patients with persistent or permanent atrial fibrillation. In the absence of pre-excitation, intravenous administration of beta blockers such as esmolol, metoprolol, propranolol, or the calcium channel blockers, calcium channel antagonists such as verapamil or diltiazem is recommended to slow ventricular response to atrial fibrillation only, however, in the acute setting. And caution needs to be exercised in patients with hypotension or heart failure. Intravenous administration of digoxin or amiodarone is recommended for control of heart rate in patients with AFib and heart failure who do not have an accessory pathway. Prevention of thromboembolic events is accomplished by anticoagulation. Warfarin or Coumadin is the treatment of choice, particularly in patients who are older than age 70 or who have a history of thromboembolic events, hypertension, coronary artery disease, left ventricular dysfunction. If the patient is unable to safely be anticoagulated with warfarin, aspirin may be given at 325 milligrams per day. This is controversial with elderly patients. You know, it's the treatment of choice for patients over 70, but these are the patients who are at greater risk for falling as well. So you end up with an increased risk of bleeding in these patients. Amiodarone is used for pharmacologic cardioversion or suppression of atrial fibrillation and with maintenance of normal sinus rhythm. A single oral dose of propafenone or flecainide can be administered to terminate persistent atrial fibrillation outside the hospital once treatment has provided safe in the hospital for selected patients without sinus or AV node dysfunction, without bundle branch blocks, without QT interval prolongation, or structural heart disease. Before antiarrhythmic medication is initiated, a beta blocker or calcium channel antagonist should be given to prevent rapid AV conduction in the event that atrial flutter occurs. For premature ventricular contractions in general, these are treated only if complex PVCs are present, the patient is 1 year or less post-MI, the patient has underlying heart disease, the patient has angina, or the patient has other symptoms. PVCs are not treated at all if the patient is asymptomatic, has a normal heart, PVCs are simple, or the PVCs disappear with exercise on a graded exercise test. Long-term treatment to suppress ventricular arrhythmias is usually selected after provocative testing in an acute care setting occurs. Drugs that may be effective include the Class 1A drugs and amiodarone. All of the drugs that may be effective are also known to cause arrhythmias, cause the arrhythmia that is being treated. So caution needs to be used when using these drugs. Again, these patients should be under the care of a cardiologist, and after the patient has stabilized, you as the primary care would be monitoring the stable patient. So how do you monitor the patient? You need to monitor for a therapeutic effect. A treatment plan specific to the patient is necessary. Total elimination of irregular beats is not realistic clinically, and usually the goal is to prevent a potentially fatal arrhythmia or prevent certain targeted symptoms. You need to monitor for toxicity. Antiarrhythmics may cause the arrhythmia that one is trying to suppress, so worsening of an arrhythmia after the drug is started may occur as an adverse reaction to the drug. At each visit, ask about specific adverse effects, monitor drug levels and changes in EKGs as needed. These drugs do have significant adverse effects that require close monitoring. For digoxin, therapeutic plasma levels should be maintained. For the patient, dosages should be decreased in persons over the age of 65, and you need to monitor the patient for development of toxicities. For quinidine, therapeutic plasma level is 2 to 5 micrograms per milliliter in most laboratories, although patient-dependent therapeutic response has been shown to occur at levels of 3 to 6 micrograms per mil. You should perform periodic CBCs and hepatic as well as renal function tests, and you need to remember that this drug has multiple adverse effects. For amiodarone, plasma concentrations may be helpful in evaluating non-responsiveness or unexpected severe toxicity. You should perform baseline chest films as well as pulmonary function tests, including diffusion capacity, before any initiation of therapy. Patient history, physical exam, and chest radiograph should be performed every 3 to 6 months. Thyroid function is needed at baseline as well as periodically during therapy, and you need to assess liver enzymes at least twice a year. The patient should obtain annual ophthalmic examination, including a fundoscopic and slit lamp examination to detect any optic neuritis, which is an adverse reaction to amiodarone. Patients should be wearing a medical alert bracelet and carry a medical identification card specifying that they're taking an antiarrhythmic drug. Patient variables. A normal change of aging is loss of conduction fibers in the heart, which predisposes these patients to benign arrhythmias. If treated, the elderly are at increased risk for adverse reactions to the medications. They may require decreased dosage to avoid possible impaired renal or hepatic function. For amiodarone, healthy subjects older than 65 years show lower clearances of amiodarone than do younger patients, along with increased half-life, 20 to 47 days. For pediatric patients, safety and efficacy of the drugs have not been established. Pregnancy and lactation, the lidocaine and sotalol are considered category B. Quinidine, procainamide, flecainide, profenone, propranolol, metoprolol, verapamil, diltiazem, digoxin, and adenosine are all category C. For category D, amiodarone, propranolol, metoprolol during the 2nd, 3rd trimester, and atenolol. For category X, you would never use these medications in pregnant or lactating women. Remember that these drugs are excreted in breast milk, so risk versus benefits need to be evaluated, and the patient may need to stop breastfeeding. For patient education, the patient should wear a medical alert bracelet and carry a medical identification card specifying that they're taking the antiarrhythmic drug. They should report any new or uncomfortable symptoms to their healthcare provider. For amiodarone, they need to be aware that photosensitivity and skin discoloration occur in about 10% of the patients taking amiodarone, and you should advise the patients to use sunscreen and protective clothing. You need to advise the patient to call for any breakthrough arrhythmia, dyspnea, or cough, and advise the patients stressed the need for regular visits and testing to monitor toxic effects. For digoxin, they need to report any occurrence of yellow halos around objects, nausea, decreased appetite, or episodes of extreme fatigue. These symptoms may indicate early toxicity. So now we will move on to agents that act on blood. These medications are for the prevention or treatment of venous thromboembolism, VTEs, which include deep vein thrombosis, pulmonary emboli, atrial ischemic events such as ischemic stroke, TIAs, acute MIs, and intermittent atrial fibrillation, as well as the prevention and treatment of peripheral arterial thrombosis. The goal of therapy is to promote anticoagulation while minimizing hemorrhagic complications through monitoring. This is a very fine line that is fairly difficult to reach. Drugs seen and used in primary care include the unfractionated heparin, the low molecular weight heparins, Warfarin, other name is Coumadin, and Aspirin. So let's take a look at heparin. Heparin has no effect on existing clots. It prevents or retards formation of any new thrombi. Heparin acts at multiple sites in the coagulation system and binds with antithrombin 3 at 2 specific sites, resulting in its anticoagulant effect. At the first heparin AT3 binding site, factor XA is neutralized, thereby exerting a direct effect on factor X. Factor X is responsible for initiating the final common pathway in the clotting cascade, which ends in clot formation. The second heparin AT3 binding occurs at the site of conversion of prothrombin to thrombin, factor 2A. With decreased thrombin available, a reduced amount of fibrin is made from fibrinogen. Standard unfractionated heparin is a mixture of polysaccharide molecules that vary in average molecular weight and composition. Typically, only 1/3 of the molecules is in a standard unfractionated heparin preparation contain the pentasaccharide sequence needed for thrombin binding and anticoagulation. Low molecular weight heparin has several advantages over unfractionated heparin. It is more predictable. It is a more predictable anticoagulant effect, along with a higher ratio of antifactor XA and antifactor 2A, thus inhibiting the generation of thrombi higher in the clotting cascade. A characteristic of the low molecular weight heparin is that it cannot be monitored with a PTT as heparin can. The use of low molecular weight heparins results in a lower incidence of heparin-induced thrombocytopenia and possibly in lower risks of bleeding and osteopenia. However, again, it cannot be monitored with a PTT blood test. The other medication that is often used is Warfarin. Warfarin competitively blocks vitamin K binding sites and inhibits the synthesis of vitamin K dependent coagulation factors 7, 9, 10, and 2 prothrombin and anticoagulant protein C and S. Warfarin is often referred to as vitamin K antagonists. At therapeutic levels, it decreases liver synthesis of vitamin K-dependent clotting factors by 30 to 50%. These clotting factors have different half-lives. Factor 8 has the shortest half-life of 6 to 9 hours versus factor 2 and factor X up to 72 hours. Oral anticoagulants do not reverse ischemic damage or lyse an established thrombus, but prevent extension of an existing thrombus and the formation of new thrombi by blocking the synthesis of clotting factors. Existing clotting factors are not affected. Therefore, the onset of action of warfarin is dependent on when existing factors are inactive. This can take several days and should be monitored closely by blood work. It's critical to understand the vitamin K-dependent clotting factors and their half-lives if warfarin is going to be prescribed. Warfarin is the #1 drug causing adverse drug effects in hospitals, sometimes because many of the clinicians don't understand the half-life times. The activity of various clotting proteins is a function of time after ingestion, including 10 milligrams per day for 4 consecutive days by a normal subject. Factor 7 activity, to which prothrombin time is most sensitive, is the first to decrease. Full anticoagulation, however, does not occur until factors 9 and 10 and the prothrombin are sufficiently reduced. Protein C activity falls quickly, and in some patients, a transient hypercoagulable state may occur. In these cases, you can see cubital necrosis. Pradaxa is a new oral anticoagulant. It's a first in-class direct thrombin inhibitor. It blocks the activity of thrombin and helps to prevent clot formation. For the estimated 2.3 million Americans that have atrial fibrillation, the prevalence is expected to increase 2.5 to 5.6 million by 2050, and this is a reflection of the growing elderly population. Approval of Pradaxa was based on the RELY randomized evaluation of long-term anticoagulation therapy trial. This trial compared Pradaxa to warfarin in patients with non-valvular persistent paroxysmal or permanent atrial fibrillation with greater than 1 risk factors. The primary endpoint was non-inferiority to warfarin in reducing the occurrence of composite endpoint stroke, ischemic or hemorrhagic, and systematic embolization. Serious safety concerns exist with Pradaxa because it has a high risk of GI bleeding. In addition, it has an increased cost. There are other drugs coming out now, and the problem with these drugs is that they cannot closely be monitored by blood work. Aspirin is also used. It's a platelet inhibitor. It prevents platelet aggregation by inhibiting cyclooxygenase in platelets and endothelial cells, thereby preventing the synthesis of thromboxane, A2, and prostacyclin, both which are potent platelet aggregators and vasoconstrictors. Dipyridamole increases the body's adenosine levels, producing vasodilatation, particularly in the coronary arteries, which improves blood flow. It also inhibits phosphoesterase, the enzyme responsible for elevating levels of cyclic adenosine monophosphate, the C-AMP, in that Krebs cycle that we all remember and love. Low levels of C-AMP are associated with reduced platelet adhesiveness. Plavix is a platelet inhibitor. It inhibits platelet aggregation by inhibiting the binding of ADP to its platelet receptor and the subsequent ADP-mediated activation of the GP2B3A complex. Again, you do not need to know this. However, you should at least be exposed and comfortable in the way that these medications work. Its effect is irreversible. Platelets are exposed to Plavix are affected for the remainder of their lifespan, which is approximately 10 days. The use of aspirin alone for prophylaxis is not recommended for the prevention of venous thromboembolism. Patients undergoing surgery who are considered to be at moderate to high risks should receive either unfractionated heparin or low molecular weight heparin. The use of graduated compression stockings and mechanical methods such as Venodyne for thromboprophylaxis, intermittent pneumatic compression devices should be added to the regimen for patients with multiple risk factors for VTE. In addition, all trauma patients with minimum of one risk factor for VTE, patients admitted to the intensive care unit, those admitted to the hospital with congestive heart failure or severe respiratory disease, and those who are immobile should receive routine thromboprophylaxis with low molecular weight heparin and mechanical methods. Patients with confirmed non-massive PEs are treated with intravenous unfractionated heparin or subcutaneous low molecular weight heparin. Patients with biosynthetic valves should receive anticoagulation for 3 months with an INR goal between 2 and 3. Long-term prophylaxis for these patients should include aspirin, 75 to 100 milligrams daily, unless atrial fibrillation is present. Patients with ball or cage disc prosthetic heart valves require long-term anticoagulation with an INR goal of 2.5 to 3.5. provided in combination with aspirin daily. Prevention of stroke in patients with ischemic or transient ischemic attacks. The American Stroke Association Council on Stroke recognizes that patients with a history of cardiac and or cerebrovascular disease have an increased risk of stroke. Those with high-risk sources of cardiogenic embolism, such as AFib, chronic or paroxysmal AFib, should be anticoagulated. In addition, systemic embolism or stroke occurs in approximately 12% of acute MI patients, particularly when complicated by left ventricular thrombus. Aspirin and VKA anticoagulation is recommended for this group. The superiority of anticoagulation over aspirin for stroke prevention in patients with recent TIAs or minor strokes has been demonstrated, and an INR of 2 to 3 is necessary to achieve substantial reduction in stroke reoccurrence or thromboembolic events. For the treatment of acute ischemic stroke, for selected patients experiencing the acute ischemic stroke, recombinant plasmagen activator or TPA should be initiated as quickly as possible within 3 hours of symptom onset, which is usually recommended. And this is done in the hospital. Recommendations have not changed from previous recommendations. Alteplase is contraindicated if onset of symptoms occurred 3 hours previously. Patients not receiving thrombolytics should receive early aspirin therapy. The use of streptokinase for full-dose anticoagulation with IV or sub-Q unfractionated heparin or heparinoids in acute ischemic stroke is discouraged and is associated with increased risk of bleeding complications. Again, these are the patients that are in hospital or experience stroke. You might see them in the office. The most important thing that you can do is get them to the emergency department as fast as possible so they can receive this medication within 3 hours of symptom onset. Currently, the administration of anticoagulation or antiplatelet agents during the first 24 hours after treatment with TPA for acute ischemic stroke is contraindicated. The oral administration of aspirin, 325 milligrams within 24 to 48 hours after stroke onset is recommended, and a small but significant decrease in the mortality and has been demonstrated. Although the combination of Plavix and aspirin is indicated in acute coronary syndromes, this combination has not been studied for acute ischemic stroke and currently is not recommended. In patients who have had cardioembolic stroke caused by non-valvular atrial fibrillation, heparin anticoagulation is primary therapy, does not reduce the endpoints of death and disability. In patients with extracranial or vertebral atherosclerosis who had an ischemic stroke or TIA, treatment with aspirin alone, Plavix, or the combination of the aspirin or extended release antiplatelet drugs is recommended. Persistent and paroxysmal atrial fibrillation is a predictor of first stroke and recurrent stroke risk. Those with persistent paroxysmal atrial fibrillation and prior ischemic stroke, TIAs, systemic embolism, or age greater than 75 years benefit from Coumadin anticoagulation at an INR goal of 2.5, the range between 2 and 3. For atrial fibrillation patients with more than one moderate risk factor, such as age of 75 years, hypertension, impaired left ventricular function, ejection fraction of 35%, or diabetes mellitus, Warfarin anticoagulation is also recommended. For patients unable to take VKAs, aspirin alone is recommended. The use of Plavix plus aspirin is not recommended due to the risk of hemorrhage, however. Evidence supporting the efficacy of aspirin is weaker than that of Coumadin, and the stroke prevention in atrial fibrillation trial used aspirin at a dose of 325 milligrams daily. However, the results of the trial indicate the best efficacy and safety profile at a dose of 75 to 100 milligrams per day. When mitral stenosis is present or a prosthetic valve is in place, Coumadin is indicated. INR should be maintained at 2.5 for those with rheumatic valvular disease, a range of 2 to 3, and INR of 3 for mechanical prosthetic valves. Aspirin may be added to the regimen. Coumadin therapy for 3 to 4 weeks duration is recommended for before electrical cardioversion. For new onset atrial fibrillation, less than 48 hours is attempted. If the onset of atrial fibrillation has occurred within 48 hours, cardioversion can be done without anticoagulation. If patients with rheumatic mitral valve disease and atrial fibrillation or a history of systemic embolism, anticoagulation plus aspirin is indicated. If the patient is unable to tolerate aspirin, Plavix is often used. For patients with mitral valve prolapse but without a history of systemic embolism or TIA, antithrombotic therapy is not recommended. If conditions coexist with mitral valve prolapse, aspirin is suggested. So for short-term therapy before electrocardioversion, to summarize, of new onset atrial fibrillation greater than 48 hours, the patient needs to be on 3 to 4 weeks of Coumadin therapy. For patients with rheumatic mitral valve disease and atrial fibrillation or a history of systemic embolism, warfarin and aspirin are suggested. If the patient is unable to tolerate aspirin, Plavix or diprimal is used. Mitral valve prolapse with a history of systemic embolism or TIAs, aspirin is suggested. Looking at patients who are pregnant, for women requiring long-term anticoagulation with Coumadin and considering pregnancy, unfractionated heparin or low molecular weight heparin should be substituted for Coumadin as soon as pregnancy is achieved. Pregnant women with acute VTEs are treated with adjusted dose low molecular weight heparin throughout their pregnancy and for at least 6 weeks postpartum. These women, as we know, are at increased risk for clotting. Alternatively, IV unfractionated heparin may be given for 5 days, followed by low molecular weight heparin for the duration of pregnancy. Treatment principles. Unfractionated heparin is administered as a continuous IV infusion on an inpatient basis. For the prevention of VTE, a dose of 5,000 units is given every 8 or 12 hours postoperatively, subcutaneously. For the treatment of patients with VTE or acute coronary syndrome, a loading dose of about 80 units per kilogram is followed by an infusion of 9 to 18 units per kilogram per hour, depending on the institution that you work at. You begin to monitor a PTT 4 to 6 hours after initiation of the treatment, so that necessary adjustments to the dosages can be made. General treatment is disconnected when the patient is past the risk of thromboembolic complications, but varies with a specific indication, as well as the institution that you're working at. Unfractionated heparin is most often administered intravenously for 5 to 10 days. If indicated, oral anticoagulation with Coumadin is given in conjunction or bridged with the heparin infusion, because the maximal therapeutic effect of warfarin is not fully reached until 4 to 5 days after initiation of treatment. Heparin resistance is seen in febrile patients and in those with active thrombus, phlebitis, infection, MI, cancer, or heparin-induced thrombocytopenia. There has been a concern about the possibility of increasing the risk of osteoporosis and prolonged standard heparin administration, mostly greater than 3 months at a cumulated dose of 20,000 units. Low-dose unfractionated heparin or low molecular weight heparin is given subcutaneously for prophylaxis of DVT, which may lead to PE in susceptible patients. Low molecular weight heparins and the anti-XA inhibitor are the preferred treatments for prevention of VTEs in patients undergoing major orthopedic surgery, such as total hips or knee replacements, or hip fracture surgery as well. Unfractionated heparin, low molecular weight heparin, is preferred for the major abdominal surgery and those at risk for DVT or PE because of strictly restricted mobility due to their acute illnesses. The use of low molecular weight as a bridge therapy has increased and is indicated for anticoagulated patients removed from Coumadin prior to surgery. For atrial fibrillation patients following percutaneous coronary interventions, or for patients discharged on Coumadin with subtherapeutic INRs. Clinically devastating complication of heparin therapy is immune-mediated HIT, heparin-induced thrombocytopenia. This is seen in about approximately 0.3% to 3% of patients. Although thrombocytopenia is associated with bleeding complications, HIT is uniquely associated with thrombus. The rate of cross-reactivity between unfractionated heparin and low molecular weight heparin is 80 to 100%. Therefore, if continued anticoagulation is needed in a situation where unfractionated heparin has been used, low molecular weight heparin cannot be used. DTI, such as agratrobin, as well as Fondra-Paranex, may be used for these patients. Coumadin may be prescribed for long-term patients with HIT. Oral anticoagulation therapy is recommended, again, for long-term use in patients with persistent or paroxysmal atrial fibrillation, acute MIs, and left ventricular thrombus, cardiomyopathy, rheumatic mitral valve disease, mechanical prosthetic heart valves, and bioprosthetic heart valves with no other source of thromboembolism, DVTs, and pulmonary emboli. In addition, prophylactic anticoagulation therapy is recommended for patients considered at high risk for venous or arterial thromboembolism. Aspirin and anticoagulation are not recommended following acute ischemic stroke, and studies have failed to show an improvement in outcomes with anticoagulation use. Warfarin therapy is often started concurrently with inpatient heparinization. Warfarin therapy is then continued as short-term adjunct therapy in DVT, post-MI, and in PEs and after total joint replacements for up to 3 months. It's used indefinitely for recurrent DVTs, PEs, chronic atrial fibrillation, and post-embolic strokes, and with cardiomyopathy, left ventricular aneurysms, valvular heart disease, and mechanical cardiac valve replacements. It may be started on an outpatient basis without pretreatment with heparin, and no consensus has been reached with regard to perioperative management of patients on Coumadin or the INR level that must be reached before surgery can be safely performed. Most surgeons will not operate with a patient with an INR over 2 and prefer an INR of 1. Loading doses are not necessary and can precipitate thrombotic events, and in rare cases, rapid depletion of protein CNS. It is recommended that patients begin with 5 milligrams daily. In the elderly, you want to only give them 2.5 milligrams for 5 to 7 days, and then adjust according to the INR. Minor adjustments then can be made because warfarin Coumadin is available in 1, 2, 2.5, 3, 4, 5, 6, 7.5, and 10 milligram dosing strength. In clinical practice, the provider will see patients who are taking warfarin in accordance with unusual dosing schedules. Many patients will take 5 milligrams every Tuesday, Thursday, and Saturday, and 7.5 milligrams every Wednesday and Sunday. This practice arises from the practitioner misunderstanding pharmacokinetics and dynamics of warfarin. There's no real clinical reason for this, and it adds to poor patient compliance. When a patient is initiated on warfarin therapy, he or she should choose between brand or generic and remain on it. However, choosing a generic can complicate monitoring because many generics are available. Patients who are taking branded warfarin Coumadin should not use generic. Minor adjustments can be made, again, because of the different dosages. Excessive warfarin anticoagulation is commonly overcorrected. Only in cases where INR is greater than 9, life-threatening bleeding or emergent surgery does warfarin require high dose, 5 to 10 milligrams of vitamin K. Excessive doses of vitamin K can create a warfarin resistance and can place the patient at increased risk for thrombosis. In most cases, it's recommended that warfarin be stopped temporarily when INR is greater than 5 and hemoglobin is stable. You need to determine the source of excessive anticoagulation, possibly include medication administration error, dietary indiscretion, alcohol overuse, acute febrile illnesses, diarrhea, new prescriptions or over-the-counter medications, any new herbal remedies or vitamin supplements. Factors that increase sensitivity to warfarin include travel, diet, environment, physical state, prolonged hot weather, increased age, poor nutritional status, weight loss or weight gain, vitamin K deficiency, malabsorption, CHF, vascular damage, hepatitis, obstructive jaundice, biliary fistulas, febrile states, hyperthyroidism, bowel sterilization for surgery, and recent surgery. Factors that decrease the response to warfarin include diabetes mellitus, hyperlipidemia, hypothyroidism, edema, hypercholesteremia, and hereditary or acquired resistance to Coumadin. The antiplatelet agents are effective for secondary prevention of stroke, patients with a history of a stroke or TIAs. Aspirin, Plavix, or a combination, Agrinox is often used. Aspirin is an antiplatelet agent of choice for reducing thromboembolic events in patients with atherosclerosis. Used prophylactically, aspirin decreases the incidence of MI and death in men older than 50 years of age and in patients with unstable angina, non-Q wave MIs, acute MIs, or cerebral vascular diseases. The effectiveness of aspirin in preventing arterial thrombosis is well documented. However, its effectiveness in postoperative prevention of venous thromboembolism is controversial. Low molecular weight heparin and warfarin are more effective in decreasing the incidence of venous thromboembolism than is aspirin. Aspirin is recommended in patients with ischemic coronary artery disease and those with mechanical prosthetic valves who have had ischemic strokes, despite adequate warfarin therapy. In patients with non-ischemic dilated cardiomyopathy, a dose of 75 to 100 milligrams per day is advised. Aspirin 81 to 325 milligrams per day is recommended as an alternative to warfarin for atrial fibrillation patients with a low risk of stroke and those with contraindications to warfarin therapy. Ticlopidine has been evaluated for the prevention of stroke, MI, and vascular death in patients with ischemic stroke. Over a 3-year period, the risk of death from recurrent stroke was reduced by 21% compared to a placebo group. The main side effects were diarrhea, neutropenia, and thrombocytopenia. Plavix is an antiplatelet agent that is used when a rapid effect is required. It has been shown to be effective as aspirin in reducing stroke in patients with pre-existing stroke or MI and in persons with diabetes. It's given with aspirin to patients undergoing coronary stent implantation, angioplasty, for prevention of acute and intermediate thrombotic complications. Diarrhea and rash are the most common side effects but occur less often than the other drugs. Resistance to antiplatelet agents has been reported, therefore an expanded role of for the combination of aspirin and Plavix in high-risk patients should be considered. The glycoprotein 2B and 3A receptor antagonists, Repro, do not allow binding of fibrinogen, thereby preventing platelet aggregation. Following an acute coronary event, these are used intravenously to stop thrombus formation after plaque rupture. A combination of aspirin and extended-release Agrinox is indicated for secondary prevention of stroke. No excess of adverse cardiac events or increased bleeding has been shown with extended release. Headache is the most frequently reported side effect. Excuse me. So how do you monitor? Coagulation parameters useful in monitoring the effects include PTT, which is activated partial thromboplastin time. This reflects the intrinsic pathway, particularly thrombin factor XA, most commonly used to monitor heparin therapy. The PT, or prothrombin time, measures the extrinsic pathway and reflects depression of vitamin K-dependent clotting factors 8, 10, and 2, used in monitoring warfarin therapy. The INR is a mathematical equation used to correct or normalize a PT result. The PT value depends on the thromboplastin reagent used by an institution to perform the tests. Laboratories report both PT and INR when a PT is ordered. This is used to monitor warfarin therapy. Pradaxa is a direct reversible thrombin inhibitor that the FDA has approved for prevention of stroke and systemic embolism in patients with atrial fibrillation. It does not require INR monitoring or dose adjustment. It does not have extensive food and drug interactions like warfarin does. Its half-life is also less than the half-life of warfarin. However, this is non-reversible. So if a patient develops bleeding, there's nothing you can do other than wait until the drug is excreted. How to monitor heparin therapy. Again, heparin, IV unfractionated heparin is monitored by a PTT, which is most sensitive to factor 2A activity. Platelets should be monitored daily or every other day when unfractionated heparin is administered IV. Therapeutic PTT levels vary with the disease state, and low-dose unfractionated heparin administered sub-Q for the prevention of VTE is not monitored. The purification process used to develop low molecular weight heparin renders it incapable of being monitored by a PTT. The patient should be closely monitored for signs and symptoms of bleeding for this reason. Oral anticoagulations. According to guidelines, the initial recommended dose is between 5 and 10 milligrams. In elderly or any patient with an increased risk of bleeding, initial dose may be less than 5 milligrams, often 2.5 milligrams. A minimum of 3 doses should be given with subsequent INR monitoring before the dose is adjusted. You should monitor the INR every 2 to 3 days until goal is reached, then weekly, decreasing to every 2 weeks, and finally monthly when stable dose and INR are demonstrated. You should obtain a regular CBC with platelets, liver function tests, stool for occult blood, and urinalysis for albumin and hemoglobin. Select patients manage warfarin using a home coagulation monitor. It's been approved by the FDA, but the level of decision-making ability required renders home coagulation monitor impractical for most patients. You need to ask the patients at each visit about signs and symptoms of bleeding, drug side effects, dietary vitamin K intake or changes, missed doses, alcohol intake, recent illness, new prescription medications, over-the-counter medications, any vitamin supplements or herbal remedies. ginkgo has been linked to prolonged clotting times. The recommended INR goal is 2 to 3 for most indications. In patients with mechanical cardiac valve replacements, the INR goal is 3, a range of 2.5 to 3.5. This is necessary to prevent clot formation. In patients with acute MI, or a higher INR may be beneficial. A lower INR of 1.6 to 2.5 may be used for atrial fibrillation in patients older than 75 years of age or who are at increased risk of bleeding but do not have frank contraindications to warfarin. Platelet inhibitors, you need to monitor for gastrointestinal upset and hypersensitivity reactions. Routine monitoring of coagulation parameters is not necessary, but you do need to monitor CBC with platelets, urinalysis, and stool hemoccult periodically based on coexistent medical conditions. Looking at patient variables, again, geriatric patients, on heparin, elderly patients may have low levels of AT3 and therefore have increased thrombotic potential. It may be difficult to achieve therapeutic PTT levels in these patients. Coumadin is difficult as well because liver function declines with aging, resulting in slower metabolism of the warfarin. Therefore, a decreased dose is often warranted. The elderly also exhibit a greater tendency to bleed into the skin while on warfarin because of the thinning of their epithelial layer. Thrombolytics in elderly you need to use with caution in greater than 75 years of age because of their increased risk of bleeding. Plavix, no dosage adjustment is needed. Older patients have renal insufficiency and a decreased ability to excrete drugs. Thus, geriatric patients may be at higher risk for toxicity. For aspirin, women do not experience the same level of risk reduction from MI death from aspirin as do men, and this may be due to greater gender differences in aspirin metabolism. In pediatric patients, the use of oral anticoagulations in children is not well documented. Heparin thrombolytics, Plavix, safety in children has not been established. Children and teenagers should not take aspirin due to Reye syndrome, and safety has not been established in children less than 18 years of age. For those pregnant and lactating women, heparin is a category C. It does not cross the placental barrier. Carcinogenic potential and reproductive effects have not been evaluated. If anticoagulation is necessary, heparin is the drug of choice despite category C classifications. Coumadin is category X. It may be safe for the fetus after a certain early period, after 6 to 12 weeks. Its use is not recommended in pregnancy because it crosses the placental barrier. Low birth weight, growth retardation, spontaneous abortion, and stillbirths have been seen when the agent is given to pregnant women. Carcinogenicity and mutations have not been determined. If a patient becomes pregnant while on Coumadin, she may need to consider termination of the pregnancy. They need to be referred to a high-risk pregnancy obstetrician or gynecological specialist. Aspirin is considered a category D and should not be taken in the last 3 months of pregnancy, especially. Agrinox, category B. Plavix, category B. No adequate studies have been reported. Heparin is not excreted in the milk, and Coumadin has not been detected in breast milk. Women who are breastfeeding may be given Coumadin after careful consideration of available alternatives. Thrombolytics and Plavix, there's not known if these are excreted in the milk. and no studies have been conducted if diatran passes through breast milk in humans. For patient education, for all patients, emphasize the seriousness of any signs or symptoms of bleeding, what the patient should look for, and especially when to call 911, especially if the patient develops headaches described as their worst headache of their life, suggesting an intracerebral hemorrhage, and when to call a healthcare provider. Encourage patients to practice safety measures and fall prevention in the home to decrease the risk of injury and bleeding and bruising. For heparin, report any hypersensitivity reactions such as skin rashes, hives, swelling, or itching. For oral anticoagulation, consistency is key to successful Coumadin treatment. Remind the patient to take the medication at the same time every day. For missed doses, caution the patient not to double up the next day dose. They should take Coumadin as soon as possible on the same day or not at all that day. Inform patient of increased risk of bleeding and signs and symptoms that indicate major or minor bleedings. Review relevant safety issues with the patient. Caution in particular about prolonged bleeding associated with falls, abrasions, or cuts. Emphasize the importance of laboratory monitoring to keep clotting parameters within the therapeutic range. Have the patient inform other healthcare providers, especially dentists, about anticoagulation medications. Their diet should be consistent. Do not employ rapid weight loss, such as Atkins or Ideal Protein. Beware of foods and their vitamin K content. The effects of alcohol on warfarin can be unpredictable, thereby increasing or decreasing the INR. The patient should be aware that many non-prescriptive multivitamin supplements contain vitamin K. Have the patient bring all over-the-counter preparations, herbs, and vitamins so that you can check the labels for any hidden sources of vitamin K. Vitamin C, vitamin E, selenium, and many of the herbal remedies can interact with warfarin. Patients should inform the provider of all preparations taken. Patients should not start new over-the-counter medications or alternative therapies such as acupuncture or massage without discussing or informing the provider. Instruct the patient to follow safety issues such as a need for a fall-proof home with non-slip rugs, night lights, and handrails to decrease risks of fall with potential for serious injury and hemorrhage. You need to inform the patient of vitamin K content in many of the common foods. Many of the high vitamin K contents, which is greater than 150 micrograms, include broccoli, cucumbers with peels, kale, red lettuce, raw mint, raw parsley, spinach, Swiss chard, green tea, raw turnips, watercress, Brussels sprouts. Those with moderate vitamin K content, which is less than 150 micrograms, include green beans, raw cabbage, canola oil, coleslaw, green lettuce, salad oil, and mayonnaise. Those foods with low vitamin K content, which is less than 30 micrograms, include apples, artichokes, dried beans, butter, cauliflower, celery, coffee, cereal, dietary products, eggs, fish, flour, fruit, tomato juice, green peppers, meat, peanut butter, root vegetables, onions, and tomatoes. Patients should be told to obtain a medical alert identification. They should wear an ID bracelet, necklace, or carry identification cards in their wallet. The fact that large amounts of cranberry juice may destabilize Coumadin therapy and that excessive consumption should be avoided should be stressed to your patient. Instruct your patient regarding the signs and symptoms of bleeding. requests that the patient promptly report any unusual symptoms or unexplained bruising and bleeding. The patient should document any missed doses and any variables in diet or alcohol consumption. This should be brought to the office appointments and included in the patient's record. The provider should stress the importance of regular laboratory monitoring of PT and INR to maintain the therapeutic clotting levels and to avoid complications of complications of therapy. Providers and patients must be aware that significant drug-to-drug interactions may occur with the addition or discontinuation of certain medications. In particular, phenobarbital and primidone used for seizure disorders and essential tremors are cytochrome P450 inducers that can impact the metabolism of Coumadin. They're the CYP1A2, CYP2C9, and the CYP2C19, as well as the CYP3A4 enzymes subfamilies. For antiplatelet agents, caution the patients that they may require longer bleeding than usual, that they may bleed longer than usual if they sustain minor cuts. Caution about their bruisability, and report bleeding, bruises, and injuries to the provider. Remind them to inform their dentists and surgeons of the drugs before any invasive procedures are performed. And for those peripheral vascular dilators, remind the patient to take these drugs with meals to minimize any possible GI discomfort. To perform regular leg exercises, daily walking is usually recommended. Patients are to walk until claudication begins. They should immediately stop and rest for 3 minutes, then resume walking. This should be done at least 8 times per day. Remind the patient that they need to stop smoking. It's an extremely important component of their treatment and will increase their risks.